After talking about surgery for back pain because of the disc and for the pain which may be patchy like knee pain, heel pain, groin pain, coccygeal pain which could be severe, uncontrolled by routine treatment, we talked of surgery by going inside the disc, cleaning the annular tear, removing the trapped nuclear fragments. Now here we are going to talk about back pain because of the facet. Now facet origin back pain, as we have spoken, is paraspinal, well localized, increases with extension and rotation, does not increase with coughing and sneezing, and it is well localized and can be pinpointed by the patient by using the thumbs. Whereas when the patient is talking of back pain in general because of disc, they use their palm to show. We need to distinguish between the facet block and the facet denervation. Facet denervation is done where the facet block has succeeded but has not given a sustained relief, and we are dealing with a situation where the pain is very intense. When we have a relief of more than 75% of back pain by facet block, which can be checked on table, that is when you block the medial branch of the dorsal ramus, ask the patient to extend on table and the patient says that my pain has gone away, you can think of a facet denervation for a longer relief. Now since these fibers, nerve fibers, contain a lot of sympathetic fibers, there is a recurrence of the pain. This recurrence is commonly seen around 2 years after the surgery because the sympathetic fibers regenerate. So we need to understand that, and we need also to pay attention to the physiology of facet syndrome, where this is a synovial joint, there is a synovitis, there could be a pannus formation, there could be a loss of articular cartilage, etc., etc. Now we also would talk about targeting the facet joint space and drawing the line as to exactly target the facet recess, the dorsal capsule and the lower recess for injection or arthrogram of the facet. We need to know that when the facet has a sagittal or a coronal lie, then our targeting would be different. In case of synovial cyst, we will be targeting the ventral facet. The dorsal facet will be targeted mainly for arthrography, and we have also mentioned that intermediate branch of dorsal ramus is involved when the patient has severe spasm. In patients who have ankylosing spondylitis or rheumatoid arthritis, rheumatoid of course commonly seen in the cervical spine, ankylosing commonly seen in the lumbar spine, the patient will have zero extension or zero movement of the facet joints. So after this initial introduction, let's go to the anatomy of the facet joint. The facet joint is composed of posteromedially facing concave superior articular process and a smaller anterolaterally facing inferior articular process. The inferior articular process is from the superior vertebra, the superior articular process is from the inferior vertebra. And if we look at this level, what we call as the lower zone, we see like this. See the pedicle, see the facet joint. This could be, if we go a little more lower down, this would be the lateral recess. This is a synovial joint with hyaline cartilage, synovial membrane and a fibrous capsule. And the joint can normally accommodate 1 to 1.5 ml of fluid. The function is weight bearing and limiting the extent of spinal extension and rotation and limiting forward sliding of the vertebra and proprioception. This proprioception is very important because that is what gives you a sense of position, especially in space. Now here you will find when we bend in the front, there is a little increase in the size of the foramen, and when we bend back, that is extension, there is a little decrease in the size of foramen. But please remember, these changes occur in the lower and the middle zone. So if the patient has increased pain on extension, the common cause is facet related and not disc related. Now it is richly innervated capsule, and it is having a lot of unencapsulated or free nerve endings in the capsule which are highly mechanosensitive, and anatomical variations are shown here, where this is L12 to this is L5S1, where you will find this is more like 45 degrees. These are different. These are more in this plane, the sagittal plane, and this is more coronal as compared to this. And there is a more overhang because the lamina is wider as compared to L12. At L12, the lamina is less wide. The distance between the pedicles is more at L5S1. It could be around 24 millimeters here, but it could be around 36 millimeters here. So this is important point of anatomy. The nerve supply of the facet joint is from the medial branch of the dorsal ramus. The dorsal ramus medial branch comes out, dorsal ramus comes out, the medial branch supplies the joint. This is the primary dorsal ramus, primary ventral, the medial branch, the lateral branch, the intermediate branch. This is mainly for the facet, mainly for the spasm, mainly for the skin. That's the way we remember. And we also know that the ascending branch and the descending branch is there. This goes to the facet. This goes in the groove on the transverse process just on the outer wall of the pedicle. Now, if the pain is of more than 3 weeks duration, with or without associated extremity pain, documented clinical findings which include patient's pain being reproduced by moving the joint, mainly by extension and rotation. There is an increased muscle tone over the joint, that you see a spasmodic paraspinal. The pain is in a recognized referral zone, and maximum site of tenderness is over the joint area. Then we diagnose this as pain coming from the facet. As you know, these are appropriately treated with conservative therapy like mobilization, manipulation by a chiropractor or a physical therapist. Passive modalities like heat, ultrasound, gentle massage, and exercise are not considered appropriate, mainly because it increases the pain. The inflamed facet due to spinal stenosis, spondylosis, sciatica, disc herniation, arthritis, or postoperative can be treated by a facet joint block, where the facet joint capsule and the synovium is inflamed. Now, how do we do this? We do it under local anesthesia. In the fluoroscopy, we go at this spot. Now, this spot is the tip of the IAP, or what we do is we draw a line which is bisecting the pedicle like this, and we draw a line at the lateral pedicle line. If you draw the lateral pedicle line and the line bisecting this, then you will be landing somewhere here, and you should never go towards the lower border of the transverse process. Why? Because the segmental artery is situated. So what we do is we put the fluoroscope AP and we put the vertebral body proper, we align it properly, then we pass a spinal needle and we go exactly at the tip of the IAP. The needle is placed on the joint and gently we go inside the joint capsule. This may also be further taken to arthrogram or may be taken to injection of the joint space. We can also inject the facet joint itself by putting it here, the line bisecting the pedicle and the lateral pedicle line, where we go exactly here. An injection of 0.1 to 0.2 cc contrast will tell you that you are inside the joint. Then we give the local anesthetic with or without steroid, and concordant pain is noted during injection, and the immediate relief of pain is noted after the injection. The junction of the superior facet and the transverse process, that is here, or a line bisecting the pedicle and the lateral pedicle line towards the upper border of the pedicle. Then a needle is put here and then we inject here. This is for injecting the nerve. Initially we talked about the joint space. Now this is for the nerve. we stay away from the lower border for fear of injuring the segmental artery. There are no complications of facet block. There may be a transient increase in pain, could be an infection because we are introducing a needle from outside. Intravascular penetration rarely. Local bleeding is known. Oozing can be there. Nerve root irritation is possible. Rarely a vasovagal shock is also known, and a bruising and soreness of that injected area is also known. Now, there are various outcomes of these procedures, and as mentioned in the initial talk, we have also published on endoscopy for rhizotomy to relieve the facet-related pain, which can be accessed from the International Journal of Spine Surgery. Now, these various studies which have been mentioned here can be summarized by going through the comments. The comments are: flaws include lack of randomization, poor outcome assessment, failure to identify the patients based on diagnostic injection, and failure to blind. Now, this is the usual talk where everyone wants a randomized controlled study, which is not very valid when you are doing these studies in a patient who is awake and aware. Now, if we go down here, the difference remains significant at 3 months, but not 6 months after the injection. The pain scores obtained by MELD questionnaire. No functional assessment was done, and use of SPECT was cost effective. So you can go through these outcome studies and you will find that this study, basically the basic technique of relieving back pain, is effective but may not last long. I'm saying just the block may not last long. So we do a rhizotomy. The indication is properly perform facet injection or a block. The innervation of the facet joint is from L1 to L4. The dorsal rami give 2 branches. The medial branch innervates the facet, and each facet is innervated by branches from 2 different levels, one from above, one from the same. Or you can say the nerve supplies the same level and then goes down and supplies the lower level on the medial aspect. The rhizotomy can be done by radiofrequency ablation. This is done by some people under GA. We prefer to do it under local. The patient is prone. Under fluoroscopy, we put this needle at the spot where we talked about medial branch. Now, this type of radiofrequency ablation sometimes fails because if we go back and see the anatomy, we will find that here at this area where the medial branch is crossing on the lateral border of the pedicle in this groove, there is a mammo-accessory ligament, and this ligament sometimes comes between the tip of the needle and the nerve, and you may feel that your block is also not effective and the procedure is also not very effective. So this may be done by a rhizotomy needle which has the electrode like function at the tip, and we use 2.5 volts to check whether we are close to the nerve. The normal rhizotomy is done by using this radiofrequency ablation. Our rhizotomy is by putting a scope inside at that site. The complications by RF ablation, you can have bleeding. If you are wrongly placed, you can have a rupture of the thecal sac, infection, vasovagal allergy, permanent damage, skin burns, etc. Now, we will be going for further surgery for sciatic pain later on in the next module. But here I can tell you that the surgery which is done for facet denervation is done by few steps like this. Number 1, we draw a line bisecting the pedicle and the lateral pedicle line, and we go straight down there, and we put our needle, then the guide wire, then the dilator, the same dilator used for the disc surgery, then the cannula facing towards the midline because we want to see the nerve. Then we put the scope, which is a 25-degree scope, which goes down. Now please remember, if you are contemplating open, that is the endoscopic denervation, please refer to our paper where we have given a detailed description, where instead of going straight down, you will have to start about 4 centimeters away from that, or 3 centimeters away from that site, and go little oblique to the side so that you are able to see the nerve. Then you ablate the nerve, you cut the nerve, so that you have a long-term relief of these problems. Now, so here we are talking about endoscopically guided foraminal and dorsal rhizotomy for chronic axial back pain. Now here what we are doing is, this is a simple demonstration of the procedure, where we are showing you that we put these needles down on the nerves, then we do a cannula, put a cannula there and do a rhizotomy, or we do it through the scope, as you can see here. Now depending on the scope and depending on the target, we may have to change the trajectory quite a bit. Here is a shorter scope which is available, and here is a RF probe which is used. Here you see the transverse process. This is the dorsal ramus and the medial branch going here. And here you can see the nerve being shown very well. There is a foraminal view of a branch of the dorsal ramus in the foramen at level of the SAP. And so this is where we go. There is a Cambin's triangle, but we are more here on the groove between the transverse process here. The conclusion of our study was medial branch nerve is more consistent in the groove on the side of the SAP. It may be covered with osseous ligaments, which would require more effective ablation than the conventional RF technique. One joint has supply by 2 nerves, one level above and same level, so bilateral 4-point surgery may be a common surgery. A dorsal ramus and its branches can be ablated from the foramen before it gets into the transverse process or the intertransverse area. There are also branches that go to the facet from the foramen, and there are branches that do not cross the transverse process but traverse the facet wall and pedicle. It is difficult to see, and often they are stripped and ablated during a foraminoplasty. A foraminoplasty also likely will involve ablation of branches of the dorsal ramus before they exit the foramen to the facet joint. Ablation of the nerves by the superior articular process will provide axial back pain relief through rhizolysis in addition to foraminal decompression. So in short, what we are saying is we are trying to highlight the point that the facet pain can be relieved by working on the nerve in this area and by working on the nerve where it is against the bone, which is very, very safe. So we can relieve the pain by burning the nerve, by ablating the nerve, and by relieving the patient totally of the axial back pain. Thank you.